So Paul's going to help, and thanks to Jeff also. You let me know, Paul, when we're going to get started.
We're ready whenever you are.
Okay. So although we're starting at 7:30, we'll go ahead and get started. This is Meg Marnell, nurse practitioner, who's been with me for many years. I'm Dr. Rob Kiltz. Welcome to everyone. And Grace is here also to help and moderate. Going to have some questions coming in through the internet, through the webinar. And we want to open this really to everything and anything regarding what we're here to talk about, obviously, which is fertility. I've been at CNY Fertility for 20 years nearly, and it's always been a pleasure to help and take care of our patients. And I think it is our pleasure and again, open to please come on in, and I think all you need to do is type in your questions, and if anyone here has a question and is afraid to speak up, please write it down and pass it around. Meg, do you want to say a few words before we get started?
Sure, absolutely. It's my pleasure here to work here also with Dr. Kiltz. I've been here for 12 years, which is amazing. And we started these support groups about 12 years ago, right in this room. And it's really evolved into a wonderful practice. It has stayed the same, but has changed nicely in many different ways. We really are trying to be present for our patients. We're trying to be there for them. And I think it's a wonderful opportunity here tonight to sort of give them our time and to be able to answer those questions for them.
And one of the things that I've learned over the years that it is tough to come into a support group and share your fears and your thoughts and ideas, and talking about this is hard to do. But we're finding that it's really important to do, because as we share our feelings and our emotions and our thoughts, it helps our cortisol and epinephrine levels go down. And that has been scientifically shown to help improve pregnancy rates. But it is hard to show up. And probably around 5% or less people show up for these. We've worked on providing online support, but it's really the personal touch that's so critical. And as we get together in a group of like-minded and similar experiences going through the same hardships, it really does help us relax. But it's really hard to talk about it. And believe it or not, it's a little uncomfortable for me even to get up and have these conversations. So I know it's got to be really hard for you guys. So thank you very much for coming today. So
Absolutely. We thank you very much for coming out, and we respect that you're here, that you have your time here, and that we're here to help you.
So we want to open it up to any questions, since I think that's why we're really here. Support questions, medical questions, diet questions, anything.
I've read many different opinions.
Mm-hmm.
I've read many different opinions on good diet or lifestyle changes regarding infertility, PCOS, Hashimoto's. Example, paleo, gluten-free. Do you have advice or recommendation on the best lifestyle change or diet regarding these issues?
A little hot topic for me recently, because I've been talking a lot about diet and paleo diet and low-carb diets, although I'm the first to tell you that for years I didn't know what the right diet was, and I thought gluten sensitivity was a little crazy. And as you look around our environment, many people are pregnant that, you think, boy, they're not having the right environment. But the more and more I experience, and I've been reading more and more regarding gluten and carbohydrates and sugar, and believe that really is what I call carbocaine, the killer for most of us, and we don't even really understand it very well. But reducing carbohydrates seems to significantly reduce the inflammation caused by high insulin levels, high glucose levels, and our habit is to eat carbs. They're cheap, they're easy, and our body wants to eat them and wants to go for them. It's hard not to eat something. So what I found helpful for myself and for the discussion is, well, what can you eat? And I've been really talking a lot about the low-carb, high-fat diets. So if you're eating eggs, bacon, butter, fatty meats, and green vegetables, and believe it or not, reducing fruit, which is mostly sugar, even though it's, quote, natural sugar, your body does not know the difference between natural and unnatural sugar. It stimulates insulin. So primarily I've been looking at dietdoctor.com. Andreas Cienfeld has really done a great job of sort of sifting through a lot of the evidence, and I found it very compelling as I've read some books, Grain Brain, Wheat Belly, Good Calories, Bad Calories, and I've sort of tossed back because our teaching has been completely the opposite of what the high-fat, low-carb diet is. So the main key here is reducing glucose, sugar in your diet, and that means pasta, rice, cereal, grains, bread, yogurt, fruit, will reduce the insulin levels and reduce inflammation. And ultimately, I think it's the inflammation that's the biggest culprit for most people with PCOS, polycystic ovarian syndrome, but also unknown causes of infertility are probably inflammatory. I did a laparoscopy on a patient today, really had no reason why she couldn't get pregnant for a second time. Hysterosalpingogram was normal, looked inside, and she had this terrible inflammatory reaction, a little bit of endometriosis, but mostly we couldn't find a cause for that. But inflammation was all over the pelvic organs and probably the culprit. Maybe diet, but again, it's just one component of the process. Did that answer the question?
Absolutely.
So look at dietdoctor.com. I personally recommend the paleo diet, but the problem is that if you look at all these diets, sometimes they recommend more of this and less of this, and they're all different. I say if you pretty much get rid of the white stuff and the fruit stuff, you're in good shape.
Thank you.
It's a pleasure. Anything coming across the net?
Yeah, quite a few.
How does autoimmune disease like Sjogren's syndrome affect fertility?
Well, I guess it gets right back to the main etiology of everything is probably inflammation. Our gut disorders, our headaches, our skin disorders, even dementia and Alzheimer's may be all related. But basically, if you have been diagnosed with an autoimmune condition, there's some cause of that we don't always understand the environmental factor. I always come right back to what do we put in our bodies more than anything else? It's food. And the food seems to be the biggest culprit, I think. Now, it may be some of the toxins in the foods, the pesticides. I think also stress. Who's stressed in life? I mean, like I always say, dead people aren't stressed. So we're all stressed because that's the nature of life. And so if you have an autoimmune condition, it may be related to your infertility because it just happens that that's the area where it might be in the skin or the gut or your other neuromuscular systems. And in many cases, it doesn't know which way to go. It's going to attack any organ of your body. And the reproductive organs, including the testes, the sperm, the oocytes, the eggs, the ovaries, the fallopian tubes, and especially if you imagine, if you wring us out and all this stuff leaks out of us, it's a lot of liquid, right? Well, the liquid isn't just water. It's a whole bunch of biochemical molecular substances, and that seems to be the autoimmune or the inflammatory or the immune system. And if you can figure out exactly how to reduce the immune issues in your body, all power to you. I don't know exactly how to do it, but that's one of the reasons we kind of incorporate a holistic and global approach, which is stress reduction, yoga, acupuncture, massage, meditation. Who likes to read good self-help books, right? So, I always wondered who likes to read self-hurt books, right? But most people say, well, I don't read very much, and I know I'm kind of around the curve here, but really it's about how do you reduce the immune system. from its hyperactivity. And it may be drugs, IVIG, steroids, intralipids, Humira, Neupogen, and there is a whole host of autoimmune drugs that I don't even understand. But then how do you reduce possibly the cause, which is, again, diet, stress reduction, exercise? I think it probably is good if you're doing walking, yoga, Pilates, light stuff. I personally think the running fast, the, what is Zumba? What else? Triathlons, CrossFit, fight or flight, right? So in a fight or flight, what hormones go up? Epinephrine and cortisol, right? And so any autoimmune condition, anything we can do to reduce it is really critical. And I would say that everyone has an autoimmune condition, just the nature of our bodies, because the immune system probably causes cancers and heals cancers, infections and heals infections. And so a lot of what we do is kind of try to bypass it as best we can, but sometimes it seems like, you know, we give steroids to reduce it, and then we give something else to try to stimulate it. So I hope I answered that question.
Our next question is, are fresh embryo transfers less successful than fresh cycles? If so, why?
So that's probably, our frozen embryo transfers more successful or less successful than fresh embryo transfers. Yeah. And there's a lot of literature going, studies that, and a lot out on the internet and in our literature, that frozen embryo transfers seem to be catching on over fresh embryo transfers. And it's not out yet, the absolute answer, because partly what people aren't seeing is that many people that undergo a frozen embryo transfer, so not everyone gets embryos to freeze. So right away you're eliminating everyone that had no embryos to freeze, so that the numerator and denominator change, and so those people that have good embryos, get embryos to freeze, are more likely to get a thaw and a transfer than many of those people that either didn't make blastocysts or didn't make good embryos to freeze. There's also some evidence that in a intensive luteal support, so the whole idea is that in the stimulation of the ovaries, the environment is adversely affected in the endometrium, the uterine cavity, that may reduce the implantation. But some studies have shown that if you increase the estrogen and progesterone supplementation, you may be able to meet or beat the frozen embryo transfer numbers. Also, for many patients, they over-respond to the stimulation of the medications, and they have a rise in progesterone. So levels above 1.5 or 2 at the time of the HCG trigger may bode for reduced success rate. So quite often, we still might choose to transfer, but not the best embryos. We might choose to transfer the lower quality and save the better quality for a frozen embryo transfer. But I personally don't think that the answer is out yet, and it's going to be modulated based on the quality of the embryos, whether your progesterone is elevated, what your lining looks like, if you're overstimulated. And if you've had multiple failed cycles, it may be time to do something different, like freezing early and then not letting them go to the blastocyst stage, so that you'll be guaranteed to have some embryos that can be thawed in the process. Any other thoughts on that? Questions?
I have a question on that. Why is it better to freeze the embryos? Why would it be better to freeze the embryos before the blastocyst stage versus going through an IVF cycle, doing a fresh transfer, being lucky enough to have a frozen embryo be frozen? Why would it be better to, I guess, instead of transferring that frozen blastocyst once it's been thawed, to instead, freeze them before their blastocyst stage and let them, I'm assuming, thaw and then become a blastocyst?
So eggs are collected and then fertilized or inseminated with sperm on day 0 of the egg retrieval. And then day 1, it's a 2 pronuclear stage embryo. And then they divide day 2 and day 3, and they become a blastocyst on day 5 or day 6. Now, the theory is that if you do not make blastocyst embryos, you were not going to get pregnant. The problem is that the laboratory may not be, for at any lab, may not be the best environment for those embryos, and that's one of the biggest quandaries to this. We've all seen cases where people do not make good blastocysts or don't make them at all, and then in a subsequent cycle you transfer on day 2 or day 3 and they get pregnant. Now the theory would be, well, those embryos were going to become blasts in the lab, but maybe not. Maybe the uterine environment is better for those embryos. So I'm getting to a little bit here. So it just may be the best way is, yes, try to take everyone to blast. You get great blasts. You either transfer or freeze and then thaw and transfer a subsequent cycle. But some people don't make good blasts, don't make them, and we have found that freezing earlier is better for those individuals. Because the problem with all of this business is we try to sort of globalize it and make it one way for everyone, but it turns out it isn't that way. And so some people may benefit from earlier transfers, even on day 2, or may benefit from freezing earlier because they don't make good blasts. Again, whether it's something inherent in the embryos or the culture condition. And yet ultimately the best is blastocyst freeze, thaw, and transfer, because that's what our best experience is. So again, it's individualized, but we sort of have a global picture of the best way. Did that answer the question?
It does. Can I ask another question about that issue too?
Yes, please.
So I've been through fertility treatments. That's why you know that. So that's why I have some questions about this. And we get lots of eggs. They all fertilize, and we get like 1 or 2 blastocysts, and they're not implanting. And we have one frozen right now. So I'm kind of along the theory thinking that, maybe, I'm not sure if, for sure, but maybe like my body and the medication, because I got pregnant on my own before, and so obviously I can implant, and I don't have any fertility issues that we know of other than the fact of my maternal age. So I'm kind of, in my mind, thinking, am I better off, and if you have any advice on this, to do, a 2-day transfer fresh if you have a lot of eggs that fertilize, or maybe trying freeze them all, and then, the next month do a transfer on, thaw them and transfer those 2-day embryos.
The one thing I've learned in this business is persistence matters, but obviously it's very challenging emotionally, physically, and financially to do it time and time and time and time again. And so if we had the ability to try one way and it didn't work, try another way, didn't work, try another way, boy, that's the beauty. But we've seen it all ways where it's not working with the blast and you transfer early. It's not working with fresh and you freeze and it works. And then don't forget the pre-implantation genetic screening, where you biopsy embryos to identify is it normal or abnormal. And that may be the culprit in 50% of the cases, or even more in some, due to advanced maternal age. But one of the interesting parts of that is that it's not just because women are older. It may be because the environment has been bombarded with all these inflammatory toxins over the years that may affect the machinery that causes the cellular division. And so working on the environment, I think, is really helpful. And yes, the stimulation may be adverse. And so once you get embryos to freeze, I really believe if you're not making many blasts, then freezing earlier the next time, thawing and transferring more embryos earlier makes sense. But again, the the answer scientifically would be, well, if you don't make blasts, you're not going to get pregnant, and it's time to move on. But I've seen time and time again where you do something different, different works.
Thank you.
Just my pleasure. How are we doing? Everyone okay?
We're getting many questions on here. The next question is, what age would you discourage IVF for a woman?
My mother's 91. Probably not a good idea. and it is interesting. So as women age, fertility rates drop significantly in the mid to late 30s, and certainly in the early to mid 40s. We, in general, tend to discourage fertility treatment or IVF with a woman's own eggs in the early 40s, 41, 42, 43. I don't know the age to tell a woman she won't or can't. I mean, we have many women in their mid-40s who get pregnant with either naturally IUI or even IVF. Now, again, not many. We discourage many. It's lower probability. But what's the number that you shouldn't do treatment for? Is it 1%, 5%, 10%, or 50%? I often find that it's the doing something that gets you something. And until you've tried, quite often, you never feel like you can move on to the next step. So I think the trial period is important. Now, 50, you look at the AMH, the ovarian reserve, the ultrasound to look at ovarian resting follicles. And in some cases, it's a stimulation to see with the gonadotropins how the ovary responds. And you see, it's individualized for sure. Over 45, the probability is less than 1%. But that's taking the whole cohort, but there may be some individuals that significantly, are better than that.
Yes.
Did that answer the question, do you think?
The next question is about male infertility. What effect does it have on becoming pregnant?
Well, it's always very interesting that if a woman's workup is normal and the guy's workup is normal, what's the problem? It's usually espoused to the woman, right? It's a female infertility problem, even though the male stuff is normal and the woman stuff is normal. But my sense is even though the sperm may look normal, morphology, motility, count, until it works, do you know it's normal? For men, it's a little bit more difficulty to identify whether something's broken or not. For a woman, you could look at the fallopian tubes if they're open or blocked. You can look at AMH levels. For men, you can check for varicocele. I think the same issue regarding diet and stress factors are important. Again, even though you can't identify whether the sperm looks normal or not, it still is a 50-50. So I say it's sperm and eggs and anatomy are really the biggest issues here. So although most of the time the woman is the one going through, or almost all the time, the treatment and much of the evaluation, I think it's important not to negate the guy. Again, sperm count, probably look at 2 samples. A urologic evaluation isn't a bad idea. Checking testosterone, TSH, hormone levels, and a good antioxidant. We recommend Theralogics, Conception XR,
yes.
and then the same thing: support group, yoga, acupuncture, hot tubs, get out of, and I haven't seen a lot on boxers versus briefs, but all these things may matter a little bit. And stop trying. That's a real tough one in our business because, it seems like you got to try harder and harder. But sometimes if you just let go, which that's not easy either, is it? It's the hard part is to let go. But how do you let go while you keep doing? And that's, I think, real important. So the guys at support group and yoga, I I was talking to one couple yesterday where the guy says he was the only guy in the yoga class, but he was there. So,
Great.
did I answer the question?
Yes.
Go ahead.
Thank you. Our next question is, what are your thoughts about embryo glue?
What are your thoughts about embryo glue? Does it sound like it should work? Right? Velcro, glue, right? So embryo glue is a culture media that's used for a short amount of time just prior to transferring the embryos in the uterus. And it supposedly has some molecular compounds that help with the embryo implanting. And we've been doing a trial over the last 3 to 6 months. I recently spoke to Michael Tucker, who came out and visited us for a day and reviewed our lab. He's from Shady Grove and is one of the top embryologists in the world. And we had a nice conversation about it, and didn't appear in his hands or our hands to increase the success rates. So it sounds good. It's equivalent to our standard embryo culture media just prior to transfer. We've also done a trial of HCG intrauterine just prior to transfer, and a few other things like the scratch procedure a couple of weeks before week before the stimulation, or even intrauterine Neupogen. And it's hard to say in any one person whether or not it's going to benefit. I think maybe the hysteroscopy and the biopsy ahead of time is valuable. I think that either sub-Q or intrauterine Neupogen is valuable, but the glue and the HCG, we haven't found a benefit. You guys did any questions on these things that I just spoken about?
The sub-Q and I don't really.
Sub-Q Neupogen and intrauterine Neupogen. So GCSF, granulocyte colony stimulating factor, which is used for cancer patients to increase red cells because they have low white and red cell levels. It's been studied in recurrent pregnancy or failed implantation, and has been shown to have a small increase in success rates, may reduce miscarriages. The sub-Q Neupogen, some people have been using it intrauterine to build the lining and prepare implantation site. So quite often we're using these things for people with repetitive losses, failed implantation, miscarriages, but they're not in our standard because they're off-label, and there isn't a lot of long-term studies that we can say absolutely are valuable.
And how is that used in a cycle versus before transfer or at? I don't understand the terms you're using. Sub-Q. How's that used?
So the sub-Q means a shot just under the skin in the subcutaneous tissue, fatty tissue, and intrauterine is where we'll inject it into the uterine cavity, so it kind of bathes the endometrial cells directly. Where the other way, it's systemic, and it may have an effect both on the uterine lining and also on the eggs and oocytes also. And if we're using it in combination to improve the egg quality, embryo quality, we'll use it at sub-Q either prior to stimulation or during stimulation. But that may also have a beneficial effect for improving implantation. And then we would also continue it as a subcutaneous shot through about 9 weeks of pregnancy. There's a lot of empiric use of these, again, off-label. The drug companies and the FDA haven't authorized them, so we're somewhat cautious, but there have been enough use that I think they're safe.
Our next question is, who is a candidate for a mini IVF cycle?
So the mini IVF cycle, so typically for in vitro fertilization, we'll stimulate the ovaries with gonadotropins like Gonal-F, Follistim, Menopur, Brevel, just to name a few. There are many others. There's pretty much the same medications used around the world. And in the stimulation for IVF, we're getting 5, 10, 15, or sometimes more eggs. Now, more is not necessarily better. The first IVF on Louise Brown was a natural cycle where you're getting 1, maybe 2 eggs. The mini IVF is closer to a natural cycle. It's an attempt to reduce the medications, so you're getting 3 to 5 eggs, usually a combination of either Clomid, letrozole, and low-dose gonadotropins, 75 to 150 at most. In some cases, you might just use letrozole or Clomid, where a standard dose of gonadotropins would be 300 or greater, which in many cases is believed to overstimulate the ovaries, and you get large cysts in the ovaries. You can develop hyperstimulation. And so the mini really just reduces the cost, the number of eggs. So if you're getting 3 to 5 eggs and you're adding sperm to the 3 to 5, you're going to get maybe 2 to 3 embryos. So that may be nicer because many people don't want to have a bunch of extra embryos around. You're less uncomfortable from the overstimulation, and the cost seems to be less on the side of the medications, but really the rest of the procedure is about the same. It's a little bit more than a natural and less than a fully stimulated cycle. And I think it's just kinder and gentler on the body. We definitely should be doing more of that. But it's, once you get there, it seems like the standard approach seems to be the primary approach. But we're really talking more about mini, low dose, a combination of letrozole and gonadotropins. My sense is if we do more letrozole gonadotropins in an IUI cycle, now you get to see how you respond to that. If you're making the 2 to 3 to 5 eggs and you're not getting pregnant with IUI, then it may be reasonable to convert, but know how you respond to an IVF cycle. And IVF is also, in some way, a diagnostic procedure where you can look to see what do the eggs look like, how do the eggs and sperm interact, are you making embryos, what do those embryos look like, how do they develop. And what's interesting is that you do a cycle and you think, oh my God, terrible outcome, that's how it's always going to respond. But there's so many other factors that go into that we don't always understand, and we wish we could just know how to do it exactly for you the first time, that it works every time, but there's also some modulation there. But natural cycle, mini IVF, and then standard protocol is kind of the sequence. Younger, less than 30, probably a better probability with natural and mini, but for many who are in the late 30s, early 40s, where their ovarian reserve isn't so great anyway, higher dose medications don't necessarily make it better, and doing the low dose or mini dose seems to work nicely. And then one other comment about the differences in the dosing. So one thing we've switched to over the last 6 months is a Lupron trigger, where previously we used an HCG trigger, and we've found that we've nearly eliminated ovarian hyperstimulation, and our embryo quality has maintained or even improved. And really just a comment over kind of where we've been over the last 6 months and prior. The beginning of the year, we really focused on protocols and being very strict on a certain number of protocols, and that everyone follows them directly and strictly. And Michael Tucker, and we had Francisco, an embryologist from Canada, come down who had extremely high rates at a clinic there, reviewed and worked with our team for the last 6 months, and we really believe our outcomes have significantly improved because we're always looking how to be and do better. So that's been really important for us.
Anybody have a question?
Yes, please.
I heard you mention Clomid and letrozole. I recently read a study that a group of women who received letrozole versus Clomid had a higher rate of live birth. In addition, ovulation rates were significantly higher. So what are your thoughts on that? Do you use Clomid or do you use both? What's the difference?
So Clomid has been sort of the standard ovulation induction medication for women who don't ovulate and for women who appear to ovulate but are infertile. So it has a good safety protocol, it's easy to take, and it has a low multiple pregnancy rate. The problem is it caused mood swings, headaches, blurred vision, and many women hated it, and the guys hated the women on it. And so letrozole has been around for a while, but it had some bad press, some potential risks of birth defects, and so it was off-label, and it's still technically off-label. But over the last 2 years, we've pretty much moved solely to letrozole, or primarily to letrozole, because more and more people have been using it. We think the safety protocol has really shown itself quite well. And we believe that it's well tolerated, side effects, the guys love it better, and the multiple pregnancy rates are still low, and the live birth rate is as good or better than Clomid. So it's our go-to over Clomid for anovulation, PCOS, and again, women who have unspecified infertility where we're either doing timed intercourse or IUI.
Can I ask a follow-up question?
Please.
With PCOS, personally for me, and I know this is a little personal, sorry everyone, I never get a menstrual cycle unless I'm on progesterone. So I've read so many different things on whether or not women who don't menstruate ovulate. Can I ovulate without having a menstrual cycle? I just like a definite answer.
Well, a definite answer, a Dr. Rob answer, a maybe. You do not have to menstruate in order to ovulate, and you can get pregnant without menstruating. And I had plenty of cases where we've seen people come in and they're pregnant, having a period of a year, and they're just pregnant 6 weeks or something. So if you're not menstruating, you're likely not ovulating. If you're having 28-day cycles, you're probably ovulating. But the only way to know if you've ovulated is if you got pregnant. And so the actual cause of PCOS, or polycystic ovarian syndrome, metabolic syndrome, is really unknown. Everything's genetic. I think there's a dietary, immunologic, inflammatory component to it, but we really don't know that answer. We've been using the dietary approach. We've been recommending metformin, which seems to help. Today I did, and I do recommend ovarian acupuncture, aka ovarian drilling. No one likes drilling, so ovarian acupuncture is a little nicer, but there's definitely some benefit if you're not responding to letrozole, Clomid, or low-dose injectables, or acupuncture, or prayer, or standing on your head, whatever it is. And quite often, usually, and you don't have to get your period, and usually what happens is they say, call with your period, and it's like you got to say, I don't get my period, so come on in for a baseline ultrasound and blood work. Thick lining, usually greater than 8 to 10 millimeters. We withdraw you with some progesterone agent, usually Provera. You get a period, thin lining, start the letrozole, Clomid, injectables. In general, you take it for 5 to 10 days, and usually starting off at about 5 milligrams of letrozole. And then we're looking for a follicle or a cyst in the ovary about 17 to 21 millimeters and a lining about 7 millimeters. Now, many women may make a follicle, but they don't have the natural surge or trigger that tells the egg to be released. And that's where Ovidril, HCG, or now Lupron to trigger the surge to mature the eggs and cause them to be released, I think is really valuable. And then either time intercourse or IUI or even an in vitro fertilization procedure is reasonable. Did that answer the question? Okay.
We have a question here. Is there any limitations on intercourse during an IVF cycle?
Is there any limitation on sex with any fertility treatment? And I don't really know the answer, but I would say no. And if we just did an egg retrieval and you're really uncomfortable, it probably isn't a good idea. But there may be some evidence that whatever the substances in the seminal fluid may actually improve pregnancy rates in some cases. Not just ejaculation, but intercourse or sperm in the vagina, and a woman's having an orgasm may have some benefits to this whole process. But it's a hard one to answer exactly. But in my experience, one of the things that happens in fertility treatment is we forget about having sex, because it's like, okay, is it time yet? Again. And really what you want to work to do is try to take care of your partners, get back to caring for each other, and I think that's really important process, and you got to have fun. And so sometimes it's about letting go, and Sarah says tequila really works, and I think from time to time it might be the thing that does help work. And I'm not proposing that everyone go out and get drunk, but it's quite amazing. It's like how people got pregnant, right? Please.
Oh, hi, Dr. Kiltz. Question about a woman going through IVF cycle. What can you expect once you have the retrieval of the eggs? As far as, you get the phone call with the embryos, and do you get a phone call daily on the updates? Does the embryologist, or is it just up to the patient to call?
So we do an egg retrieval, and you're out. The woman's asleep, and we used to allow the partners to be in the room, but we've sort of changed things, and just based on what top centers are doing in this world, cleaning things up, so the husband's not, or the partner's not in the room to know what's going on quite as much. But we like to give an update after the procedure, although the woman might not remember very much how many eggs. And then a few hours later, we inject the sperm into the eggs, and then the next morning we'll know how many fertilize. And typically about 50 to 75% of the eggs will fertilize, and that's the first call you should get from our team, and it's going to check how you're feeling and how many eggs were collected, how many were mature, how many injected, and then how many fertilized. And then we'll give you a date to come in for your embryo transfer. We like to put the embryos to bed and keep them quiet. We actually have a new culture technique that we're working on, which is a one-step. Basically, you put the embryos in the incubator and you leave them. You don't open them until the proposed transfer date, which is usually a day 5 or day 6 transfer. So that's the only next time you're going to get the update in general. But if we are currently and have been looking them on day 3, because on day 3 is the average cleavage stage where we should see 6 to 8 cell embryos, and we could look at the quality a little bit, and you might get an update call or come on in because we think you should do your transfer today, or your embryos look really great, we think you should wait to day 5 or 6 and don't come in, or you come in and we have the conversation. We would love, and we're moving towards the camera system, but currently the cost and the improvement in success hasn't quite met the expectations, but that's going to be the next level where literally you'll be able to go online and watch your embryos develop and keep an eye on them, which could be very nice, but it could also be a little deceiving. Oh my God, what does it look like? What does it mean? Let me give a call. And we would love to, and we want to call and talk to everyone every moment about the update. And our embryology team is usually very good about answering questions. And if they're not, I want to hear about it because I think overall they're working really diligently to do that. So our job is to call you the day of day after fertilization and give you an update. Also, after they've been transferred, if there are embryos left over that potentially can be frozen or will be frozen, in your portal should be a letter that give you an update the next day or two. If there's any questions, we encourage you to either correspond with us or call us, and don't hesitate to do that. And I certainly apologize if anyone misses a call or doesn't get a call in a timely fashion. So always call or email or correspond. We're really working towards our EIVF patient portal that more and more communications can be performed that way. And the nice thing would be, here's a picture of your embryos. They're looking great. Go to sleep tonight and relax, and we'll see you in 2 days.
So what determines whether they look at them at day 3 or they just let them go till day 5?
So currently, almost all of our embryos are looked at day 3. The new system we're looking at right now is to put them to bed until day 5 or 6.
Oh.
So right now, everyone pretty much gets a look on day 3, but not everyone gets a call. It really is if you were scheduled at day 5 and they look good and there's no update to call you, we wouldn't give that call. If you're curious, you're always welcome to call. If we thought, boy, sometimes we look at them and say, we think we should put them in today, we'll give you a call and let you know that. Recently, we've been talking about scheduling everyone for a day 3 look and call, and then that call would say, yes, come on in, or they look great, stay at home, we'll see you on day 5 or day 6. And I say day 5 or day 6 because those are the blast days, and day 2, 3, and 4 are cleavage cell days.
Can I ask a follow-up?
Please.
Okay. So if I have a day 5 transfer, I really don't know how many embryos I would like implanted. So thoughts on that? This, varies with age, I assume.
So the question is how many embryos to transfer, and it depends on the woman's age, the number of cycles, and the number and quality of embryos. So in general, less than 35, it's 1 or 2. Less than 30, first or second cycle, high quality embryos recommended as 1. I would tell you that most people want to do 2. We offer it, we recommend 1. So multiple failed cycles, quality isn't as good, and we're going to the blast stage. You might do 2. 3, over 37, multiple failed cycles, not as good a quality. But great quality, even up to 39 and 40, it's up to 2. 40, 41, 42, 3, and rarely 4, and almost never more than that anymore. You know, the interesting part is that nature knows what it's doing under most cases, because the majority of embryos are chromosomally abnormal over 39. By putting in those extra embryos, you're rarely going to get multiples, triplets or quads. Rare, but it's just rare. So 1 or 2, I would say, is the average for most people doing blast. 2, maybe 3 at the cleavage stage over 35. Under that, it's 1 or 2.
So, over 40?
Over 40, 2 to 3, and occasionally over 42, you might do 4.
Okay, thank you.
But you're doing that, understanding the quality, understanding also the risk, and if the risk is, we think, and all converse that triplets or quads might be too high, or I would never reduce. We know that that's a small risk, but it's not a zero risk. We have a giveaway that's going to happen at about 8:30. Yeah, and it's going to be emailed to the winners, and we are going to be doing this in the holiday season,
That's right.
which seems to be getting closer and closer. And keep with us. Any other questions?
We have a question. How many mature follicles are ideal for an IUI cycle?
Do you want to take any of these, Megs? I seem to be hogging all this.
I think you're doing a great job.
Thanks. Well, so for stimulating ovaries for an IUI, 3 mature follicles is sort of our target number, because in general, if you're ovulating regular cycles and you're infertile, open tubes, normal sperm, you're usually making 1 follicle. By boosting the number of follicles and doing insemination, you're going to double your pregnancy delivery rate from about 5 to 10% to about 10 to 20%. Now, if you're over 35, 4 or 5 are not so unreasonable, but it does come with some risk, as we all know. So you sort of modulate that a little bit. If your problem is anovulation or not ovulating, then we're going to recommend fewer follicles, 2 to 3, or even in some cases 1 to 2 for an IUI cycle. So anytime you have more than 3, we're recommending canceling and converting to IVF. Anytime you have 2 or 3, there's some risk of twins and triplets. You need to understand that. And but it's still going to be in the 10% to 20% risk, but you're still going to double or triple your pregnancy and delivery rates by doing the ovulation, induction, and insemination. I personally think that's why the injectables are better than the letrozole, because letrozole and Clomid in general are going to make 1 or 2, but some people make 5 follicles with Clomid and letrozole, and they're a great candidate with IVF, and that's a great mini cycle. I saw some hands.
Yeah, I have a question. Going back.
I'll repeat the question.
So going back to the IUI and the number of eggs. So I guess getting personal again, but I'm over the age of 40, but I produce a lot of eggs, and they're all mature, and we're getting like 95 to 100% every cycle fertilizing. So I'm being told, even though I'm older, these are all good things. I may not fit into the average because my AMH level is normal. Everything about my testing is normal. I'm just older. So, we talked about this, and I keep thinking about this IUI because, in my mind, I can't help but remember we got pregnant on our own. Maybe, if we have 7 or 8 eggs in there, what's the chance of me really getting 7 or 8 pregnancies because I'm older? Is that, or you won't do IUI with someone like me because maybe they're all good eggs. The theory being like when you're older, you're probably not going to have 100% good eggs.
So over 39, a lot of failed cycles, miscarriages, more eggs, you may go ahead and take a risk with an IUI, because the same thing with IVF. We know the majority of those embryos are probably abnormal, and that's why injectable IUIs have an improvement in success rates, because it's the same thing. More eggs, more sperm into the environment increases the probability of success. Now, if you're taking someone that doesn't ovulate and is younger, that's not the scenario to do that. But someone who has an unknown cause, that you're probably reasonable, but you have to understand the risk, and you got to be really cautious about it. And I would say that in the last few years we've done really very few reductions, because I think we've picked and chosen well, but it's not 0. So the answer is you could take the risk with more eggs because you failed so many times.
But given the choice, if you were financially able to, would you still say IVF's the better option than IUI under those scenarios?
I think it is, but this is a weird business. That why one thing works and another thing doesn't, I don't know. And, we always think we can't go back, but we're not. We're just going on to something again. And it's persistence in the process that matters more than anything. Obviously, we're always trying to tweak it and change it, but like rolling dice, the more you roll the dice, you're going to eventually get the number. This is the same business in some way. Positive approach, reduce stress, change the diet, and do something. And what I've seen more than anything, the positive attitude, it's going to happen, I'm going to do it, it's going to work is the thing that's gotten the success as much or more than anything. And why it works sometimes, I scratch my head. It's like I predicted people it's going to work on it didn't, and the people it isn't, and it did. So this is a mystery game in so many ways. Question?
What do you recommend as the minimum sperm count to have an IUI?
1. 1 egg,
It only
1
takes
sperm. But in general, we've had pregnancies and deliveries at 300,000, right? And we often look at it and we go, oh, this isn't going to work. How do you know? You didn't do it. I always say do it. Now, 5 million and above, 10 million and above are kind of the numbers we talk about more than anything. But the majority of sperm in the vagina is killed off or is lost out the vagina. A small amount gets up into the cervix naturally, swims up, and's got to work really hard against, all the factors that are saying get out of here. And so the IUI, or intrauterine insemination, concentrates more motile sperm. And if you have a low count with intercourse, then an IUI count is going to be better than that. Many people have coverage. I always say it's worth a do. And so, quite often I work for us not to be naysayers and negatives in this process because it just takes some sperm to help get it there. And so we've had 300,000. So that's my low number. IVF with ICSI is the better process, but that's a tough process, and why it doesn't work or works, I don't know. Question?
Can you explain the trigger time versus when the IUI actually happens and what is recommended?
So the trigger time between trigger for a mature egg and when to do IUI, intercourse, egg retrieval. So the egg post-ovulation is receptive about 12 hours, we think. Right? And after the trigger, we think in general, ovulation occurs about 38 to 42 hours later. When we do an egg retrieval at 38, 95% or more, we get an egg out of there, all right? And so there's been lots of stuff out there. We have found that anywhere between 12, 24, and up to 36 hours later for either IUI or intercourse is going to get the majority with good, normal, viable sperm equal pregnancy delivery rates. In some cases, when it's not working, 12 and then 36 hours of double IUI we think has some benefits. So the window is wide, especially if you have good viable sperm. And the important thing is we think to get the sperm in there before you ovulate. That seems to be the important part, because if it's after ovulation, it may be there's a shutdown that the progesterone rise begins to block off the normal transport of the sperm ability to swim up through the female tract. But there's a lot out there, and we in general trigger 12, 24, and 36 hours. We find that it works equally well if you have normal counts. Any comments? Okay.
We have a question about support. Is CNY Fertility supportive for single moms by choice? And do you have a support group for those who choose that?
Do we have a separate support group for single women by choice? I don't know that answer.
We have a support group, and they are more than welcome to come. We also have peer support, which would be helpful, and we do have many single women who are involved in that peer support.
So I like to think that this is a family, that we're working with everyone and anyone who wants to build a family. And quite often we feel uncomfortable because we're not seeing like-minded or like-looking or other people in the same group. but it's important that as you show up, other people will show up and join in the process. And again, it's simply showing up. We're herd animals, and the village is important. And women talking is really critical to shifting the oxytocin, the serotonin, reducing the cortisol and epinephrine. And whether it's on our Facebook or it's Fertile Friends and a call, and Lisa Stack is available for individuals, even calling me, texting me. I take a lot of calls. I talk to people because it's the support that really matters in the process. And so I hope that answered the question.
Great, thank you. And what is a high quality embryo to you?
A high quality embryo is one that makes a baby.
That's right.
And it's really kind of interesting because I always see plenty of little babies, and I got one mom who shows me the picture of the ugly embryo that everyone said don't transfer, and it's her beautiful son. And so I've always said our ability to look with our eyes is really deceiving. And the universe, you know who I'm talking about, knows what they're doing. And so if you're growing an embryo, whatever the quality is, our ability to answer its goodness or badness isn't so great, because embryologists and doctors are very subjective in the process. And although we're giving guidelines, I've seen an embryo look really, you know what, bad, and then an hour later look like, wow, this is a spectacular embryo. So if we're transferring that embryo at any one moment and we have an opinion about it that might not be what it's really about, I think we should shift it. So would you tell a child they're lousy, they're no good, or ugly? I hope we wouldn't do that. So my philosophy, although I understand grading, I understand what we have it for, it is really for us to look at a cohort of embryos and pick that embryo which we think is the most likely to implant. That's what it's there for. It's not there to say you will or will not become a baby. That answer it? Any other questions or comments? Please. I don't think they're going to cut us off right at 8:30. Is that right, Paul? Okay.
Does the quality of the embryos decrease as linearly as you age, or at like exactly 30? So if I'm in this situation, should I freeze at 28 now, or should I wait till 30, 35? You know, when should I be freezing?
So are we talking about freezing eggs or
Eggs.
embryos?
Sorry, I said embryos, but I meant eggs.
You're as young as you'll ever be now.
So it's better to do it now. Okay.
So it's better to freeze eggs or embryos or sperm today, unless there's some things you can do to physically, emotionally get yourself in a better spot that may prepare you for the process anyway. So there isn't, you know, although the studies kind of show this linear, if you took an individual, our ability to predict it based on your age or AMH or FSH isn't really that great yet. And so I think that today is still the best day if you've got all those other parameters set.
Okay. Can I ask more questions?
Please.
Sure.
How does insurance work? Is there any chance, or?
Insurance may cover egg freezing. It depends on what your coverage is. If you never ask, it's always a no. If you ask, you have a 50-50. And so there's some ways to do it. Depends on if there's other mitigating factors that might require that. I don't know what the financial cost is off the top of my head, but it's something that, you know, please feel free to call us. I don't know if we have it on the web right now, but it is available. And there may be some reasons to talk about whether or not it really is something you should do. I don't even know the answer whether or not all young women should start freezing their eggs in order to preserve their fertility, because the real odds of their fertility at 30, 35, or 40, we don't know how different. Now, 28 compared to 40, big difference. 28 compared to 32 or 33 may not be such a big difference. But, you know, it's hard to look back and go back. And so my sense is eventually egg freezing will be a much more prevalent thing to do, where a combination of you might opt to freeze your eggs, and if you never use them, either donate them to research or to donate them to another couple to have a child in the future, if that's something that you might consider.
Okay, one more question?
Please.
So it's about presently, if you're using contraception, you're in a relationship in which you're not ready to be pregnant in. You go off contraception to do this procedure, I presume, for a month, or for how long, or how does that work?
It depends on the contraception, but you don't have to go off your contraception in order to do the treatment. So an IUD could stay in place. A birth control pill you could stay on, because typically you'll stay on the pill, will stop the pill and start your treatments, and then start you back on the pill after that.
So you'd be off the pill for a month, so there's a risk that you could...
You'd really be off the pill only during that stimulation phase, and so then you'll retrieve the eggs, and theoretically we've collected all the eggs. And right. So it's not for really just a short amount of time that you're at risk around the ovulation or the egg retrieval, because we might not get every single egg, and you might pop an egg out, and you may be a little bit at risk over that short amount of period.
Is the short amount of period like a week?
It's about a week.
Okay. And then, so if I'm thinking of a different type of contraception. So right now I'm on the oral contraception. I'm thinking of getting the Implanod. Which of those is less interfering with this process, the most seamless? Which should I do? Is it okay for me to change to the Implanod now, or should I wait until after I get the procedure done and remain on oral contraception for this time?
I've been recommending stay in the oral contraception because the progestin inserts may affect stimulation, and so in general it's a hard one. You don't want to go through this procedure and have some effect that I would say that 75%, 85% of people do fine, but there's a 15% plus that might not have a good of stimulation as they would otherwise.
Thank you.
It's a pleasure.
Okay, we actually have until 9 for the webinar, so we still have a good 25 minutes or so. We're actually live on Facebook right now. We just got a question come in from our Facebook page. What does it mean when your embryo has too many cells? This is something that I was told during my IVF cycle, but I never asked what it meant.
So when embryo has too many cells, is probably speaking towards that it's a multinucleated embryo, a polyploid we call it, where an egg is typically injected with one sperm, but occasionally multiple sperm may fertilize an egg, or for some reason there's some abnormalities with the cleavage that causes the number of chromosomes. So rather than 2 sets of chromosomes, there might be 3 or more that may affect the normalcy of the embryo. Now, what's very interesting is that embryos may self-correct, and so that's why PGD, PGS isn't always accurate. Our ability to look at an embryo isn't always right. So that's why I always think it's best to watch the embryo grow to the cleavage and even to the blastocyst stage. And a biopsy of an embryo might come back normal and be abnormal, or abnormal and actually be normal. And so nature kind of knows what it's doing most of the time. That's kind of why I'm not a proponent of PGD, PGS, or pre-genetic testing, but it still has some value in the right cases, and possibly even better to identify, we thought an embryo was abnormal based on its fertilization. Let's check and see and better identify whether it is or isn't. And just to add to that, many centers are recommending more and more pre-genetic diagnoses where you biopsy the embryo, and all those abnormal embryos get discarded. So if you had no normal embryos, you never got a transfer. You were never included in the data that's reported to SART. And so many clinics seem to be kind of hiding some of those numbers that may boost other people's success rates and may artificially show lower rates in others. So that's another thing to keep in mind with both the freezing and the biopsy of embryos, which you may not know by looking at the SART or CDC statistics.
We had one more question from our Facebook page. When using IVF after a failed vasectomy reversal, what are the options to obtain sperm, and are these sperm usually of good enough quality for fertilization?
So someone who's had a vasectomy and an attempted reversal where it's failed, the success of IVF is equal to the fresh ejaculated sperm, or a successful reversal where someone just wasn't getting pregnant. In general, we're aspirating sperm out of the epididymis with a small needle with a local injection of an anesthetic. In some cases, it may be recommended to collect sperm prior to the vasectomy, or when you're doing the attempted reversal, to collect sperm and freeze it at that time. So if it's a failed reversal, then you'd have that sperm, and the success rates seem to be equally as good. In some cases where we're getting no sperm from an aspiration from the testes, we will do a needle punch biopsy directly in the testicle, and that may find sperm. Yes, it can be a little uncomfortable. We do it either under local or general anesthesia, but more commonly local. And in some cases, it requires an open biopsy where you open the scrotum and take the testicle out. Now, you know, guys, it does seem terrible, but women go through a lot more in the process. And so it's a little bit of a pain, but we have methods that really minimize the pain and discomfort. Occasionally, we'll find someone where we have no sperm even after a reversal or a failed reversal, and we come to find that someone might have been taking some testosterone, which is not good because it reduces sperm production, or a supplement that they didn't know had some testosterone that might also reduce the sperm production. We occasionally will add HCG or Clomid, letrozole, which might help with that. And if all else fails, obviously, donor sperm is the next set. Either a known donor, a relative donor, or anonymous donor. And we're currently working on a donor sperm bank in order to provide lower cost donor sperm, because it is really very expensive out there, and we want to make it a lower cost option.
I'm getting a lot of feedback on Facebook, and people are saying that their questions haven't been answered yet. We're getting quite a few questions online coming in. There's quite a few people on the webinar right now. So if we don't get a chance to get to your question tonight, please email us. We'd love to hear from you. Go to cnyfertility.com or info@cnyfertility.com is another great way to reach out to us.
And Meg and Lisa and myself and my other docs, Dr. Grossman, Dr. Ditkoff, Dr. Arroyo, our practitioners will all work to answer these questions directly on Facebook or through our website. But these are important, and we really want to increase the connection in knowing that these questions, comments are really important to us, because we can't do better unless we hear directly from you either what we're doing wrong, and we want to hear that, or what we can do better, or the things that we're just not getting to which are important to you.
I have a question now. Can certain sex positions increase your success in getting pregnant?
You know, sex in a Volkswagen years ago seemed to get you pregnant when you didn't want to, right? and you know, I don't know that answer. I don't think it's easily answered, but in general, sperm falls out of the vagina after intercourse. And so mission, bottom up, for 10 to 15 minutes afterwards may be beneficial. Someone else out there might have a better answer than I do. I don't know it. Standing on your head might help, but it probably isn't the best thing to do. So, any comments? Anyone have any other experience? Help me out.
What are your thoughts on stroke stroke OTC?
Over the
Oh, it's a
Stork OTC?
Have you heard of that?
I haven't heard of Stork OTC.
It's a product found online.
What supplements do we need? Oxygen and air. Water is really the thing we should be drinking the most. Fresh, fatty meats and green vegetables. You get all your minerals and vitamins from that. We do sell and support some supplements, vitamin D, folic acid, fish oil, CoQ10, DHEA. I don't know about this one. I sometimes talk about...
What is it?
It's a home conception device using cervical cap insemination. So it's an actual tool.
I don't know much about it. I'm sorry, but the idea maybe is: are you doing home insemination, which putting sperm in the vagina can work, and the cervical cap can work. I have no experience with it, but there are a lot of most things are a home remedy, right? Because you're having sex at home. And that's part of what we should be working on, all those home remedies, how to make your home the castle and the environment to best improve your odds. And so I can't comment on it. I'm sorry.
Okay. Does alcoholism have an effect on male fertility?
Does alcoholism have an effect? Any drugs that are not really meant to be in our bodies adversely affect our libido, or sperm quality, or egg and embryo quality, affect the outcome. So I think
and overall health too.
Yeah, and definitely overall health. I mean, it's water and the things I mentioned, and so any drugs like that, I think, adversely affect your fertility. And people talk about 1 or 2 glasses of wine or beer is healthy for you. My bet is it really isn't. But we've been convinced by the food industry about things that aren't good because there's some study that they found that it was helpful. But my bet overall, it's not helpful at all. So cutting it out is good.
Thank you. Does the likelihood of becoming pregnant increase with each IUI cycle?
The more you do of anything, the greater the probability of that outcome you wish. And so that is so if you do 2 IUIs in a cycle, may increase your probability, but one well-timed, I always say within the 12 to 36 hour window, is going to give you a reasonable probability. And I've got a nice graph that I've been sharing. I've been working to get it to send out to everyone. So if you're in the 30% bracket or 40% with IVF, 6 cycles is going to give you about a 95% chance of delivering a baby. Where if you're in the 10 to 20%, it's going to be in the 60 to 70% range after 6 cycles. So the more you do of anything is going to increase your probability. That's why I really work to make it more affordable and easier and more accessible for the process. And although the emotions will stop us faster than anything, and we are emotional beings, and so it's emotion. So that's our energy to keep us moving. Sometimes you got to yell about it. You got to be emotional about it. You got to cry about it. a pillow is the best thing to use to beat someone with, not a bat, right? Pillow or a towel or something like that, and it's okay, because when you do it, don't you feel better? We got to get them out. Don't hold them in. I am accused of holding things in a little bit or being a little too positive. It's my mother rubbing off on me. Did that answer the question?
Yes.
Can we get a question back here first? Go ahead. I'll repeat the question. So if you're unable to conceive and deliver a baby, we call that infertility. But so I mean, it's just that's what it's called. And I'm not disagreeing with you. I agree with you, but just to kind of hear the term out there. So if you're needing us or someone to help in assisted reproduction, we call that infertility. And so if you've had your tubes tied and you've had children and you've donated, you're probably more fertile than most. And so it may be that you require less medications to stimulate your ovaries, more be a better candidate for either natural or mini IVF, low dose IVF for the process. But it really is. It's not like, it's a 95% chance. It's a slam dunk. Unfortunately, you fall into the 50% range per cycle delivery rate, under 35 in general for that. Did that answer the question? And you're right, though, because I like to use we're fertile, because the words we use create the energy and help us in the motion. So we're working on our fertility, not on our infertility. So thank you for sharing that.
If insurance doesn't pay for it, what are the options? Is there like a payment plan, or do I go to my bank and get a loan? What's typical?
So we have some single cycle, multi-cycle plans and we have some payment plans, low down, no down. I mean, we've kind of working to shift it, because what's happened over the last year or two is the insurance companies and their insurance plans have very high deductibles, and even though New York State is a mandated state for fertility diagnosis and treatments, not including IVF, many insurance employers have gone to self-funded plans that don't fall under the state's mandate. Even the state is not under the state's mandate, which is kind of interesting. So I'd say go to your employer, and you gotta push your employers or our state and federal governments, because we all have to be proponents for it, because ultimately family building is the most important. I'm a little selfish in that, but I think ultimately reproduction is really what we're all about. And so talk to our financial people, ask the question, we'll help you figure out a plan. And saving for the future is one thing, but what does it cost to have a baby? Right now, a baby's in my arms. What does it cost per month to take care of a baby? It's more money than people understand, and quite often people say, well, I can't afford fertility care, but they'll somehow afford a baby. If you put the money in your fertility fund now, you'll be more likely and able to afford the fertility. There's some grant programs available, and also some of the pharmaceuticals have some plans where they have medications. Search the net. You may find more affordable options. They're the same medications produced around the world. I'll leave it at that. That answer your question? But talk to our financial girls. They're wonderful. And if they can't answer it, say, where's Dr. Kiltz? I need to talk to him. How's everyone doing? Does anyone feel like something hasn't been asked or approached? Something really stupid? Afraid to ask?
Well, kind of off the last question, one of the questions we got was, it seems like CNY Fertility is more affordable than a lot of the other clinics around. And the question was, can you speak to that when looking at IVF cycles?
So, although some people will get me for this, I say Walmart prices, and we work to be Ritz-Carlton service. Now, it's not inexpensive. It definitely is expensive. When I started this 20 years ago, I was delivering babies at 2 o'clock in the morning, making less than $2,000 a delivery after 9 months of care. And I couldn't understand why people charged as much money as they do for IVF. So through the years, I've worked to keep it affordable. I'm no different than any of you guys out there. I definitely make more money because I've worked hard for very many years, and I'm nearly 60, and so for whatever reason I'm there, but I still work diligently to try to make it more affordable. And people ask for, what can you do? How can you help? Can we make payment plans and work on that? And so it's just been my mission to work to make it more and more affordable. And I've always thought that if the coverage could at least help people through the IUI phase, how come they can't at least provide the medications and the monitoring and things like that for the IVF phase? And again, it's something you have to go to your employer, insurance companies, and the government and mandate that. So again, it's just a personal mandate for me. I grew up in LA on the streets, didn't have a lot of money, and I had to work and pay for all of my schooling personally. And I have very amazing parents. I was kicked out of school, couldn't read, grew up in LA in a gang, and through a lot of love, a lot of great people, and my amazing parents, I'm here where I'm at. And I don't do this alone. I do this because an amazing group of amazing people that work with me that help support me and support you guys. I'm one doc, but my nurses, my nurse practitioners, and other physicians and support staff make this place. And some people say, well, Dr. Kiltz or the doc's not always around. I may not be right in front of you, but I work diligently to be accessible. My cell phone, 315-416-9872. And text me, call me, and I give it out to as many people as possible. Many people never call me, but please, my staff is amazing. And I'll probably be killed tomorrow by some people about that, but my fiance, Miss Sweet Tia, who I love dearly, says turn it off, and I work to do that and turn it off and be present at those moments. But I'm here. This is what I do, and I'll die doing it. And so I retired when my obituary comes out. And my grandmother died at 105, and my parents are 91. I'm not going anywhere.
We're very happy about that, too.
Although my kidney stone last week kind of put me down a little bit, but I was still working.
Can you say your cell phone number one more time, please?
315-416-9872. It's there. And email me, text me, although I don't always get it. I get a lot. I miss it sometimes. I pass it on to the nurses because they can help me and answer the questions that I may not have all the time. I'm in the OR a lot. I'm doing procedures and occasionally have to turn it off. But again, I pass it on. Any other thoughts, questions, comments?
Are you looking to open another office in other states?
Well, we have a lot of we see people from all around the world, and we work with a lot of other OBGYNs and monitoring centers, and we're working with some docs in Colorado, in California, in Florida. We've been working to open up our Buffalo office for some time. We finally are, after a year of trying to get a permit, open up a building. We have a doc that's working there, a practitioner. And so really we're here to help and work with you wherever you're at. We have a great travel team. And I personally have learned that this is home base. And I've got to work to stick to it as much as I can. But we work with, again, a great, amazing staff and team to help in the process.
So actually, we can say that from any state, you can come here. We can do monitoring in your local state, at your local doctor, and come here for egg retrieval and transfer, and also our Albany office, too.
And I've been amazed. I came from Los Angeles to upstate New York and thinking, okay, this nice, quiet little upstate town. It's a small village in some way. I live in Skinny Atlas, and I was amazed. We see people from all around the world, and they travel here. I think I have a great staff, and it's just amazing. And obviously our prices are different, and that's just a personal intent on my part to work to make it more affordable, because building a family should be that.
Are there any more questions, Grace?
Do we have time for another question?
Silence is really important. Morning meditation, visualization, and intention. So pictures of you, your family, pregnancy, babies are hard, but do it. The brain knows how to make babies. And faith and a positive attitude as much as you can, but it's practiced like anything else. I've been practicing medicine. One day I'll know how to do it, and but we're all practicing at whatever we're doing, and that's real important to me, because I practice it, and I've learned through that, through reading, listening, and talking, and thinking in the intention that you desire, the dream will come true. One more question.
How does PCOS affect infertility?
How does PCOS affect infertility? Well, it's interesting. Many polycystic ovarian syndrome women are fertile, and a large number of them are infertile. We mostly think it's related to not ovulating, and simply helping a woman ovulate would help them get pregnant. But it's not so simple, because either they're not easily ovulating with simple procedures like Clomid, letrozole injectables, or there may be other, I think, immune or inflammatory processes going on that can be fixed by shifting the environment, mostly, I believe, the diet. And again, carbs are killers, carbocaine, I call it. We want them because they make us feel good, and we're driven to them in order to survive and thrive. But in today's world of Wegmans and McDonald's, et cetera, and easy foods, I'm back to, you cut those out, eggs, bacon, and butter in the morning, your appetite's suppressed, and a nice ribeye steak with some green vegetables for dinner, and get rid of the almond flour, rice, all this stuff that's trying to mimic what you normally eat. You got to get rid of it, because I don't think it's good for us personally. So I think it's ovulation, but I think it's also inflammation, which ultimately is the thing that keeps us alive and kills us, hopefully a long time from now.
Can metformin help with this process for the patients with polycystic ovary syndrome?
So I think metformin, Glumetza, the oral glycemic help with the insulin resistance seems to help in reducing the effects of the high insulin and glucose levels, and it may help many women lose weight. And if they do a high fat, low carb, no sugar, it really is powerful. And if you watch a couple movies, Fat, Sick, and Nearly Dead, Fed Up, and if you go to dietdoctor.com and you look at his beginner video, I think you'll find a lot of great info. Michael Fox is a reproductive endocrinologist in Florida, where I learned a lot of this from by watching his videos and reading his stuff. But if you gotta listen and read the information. The brain tells the body what to do, and then it becomes easy. But if you're not putting it in your brain constantly and shifting it, and you watch TV, you listen to news, you constantly want to eat the bad stuff, because it's like the cocaine in the cupboard, and you got to throw it out of the cupboard completely.
So thank you, everybody, for coming, and all those on the webinar. We appreciate it. Thank you, Dr. Kiltz and Meg, for answering a lot of these questions. Congratulations to our giveaway winners. You should have received an email, so if you got an email, congratulations. Also, again, if we couldn't get to your question, please feel way to reach out. There's a bunch of different ways to do that, but everybody is ready and willing to take your questions, and we can give you some good answers.
And those text or calls may not get right away, but we'll pass them on. And it really is my pleasure, and thank you very much for sharing. And we look forward to another event very soon. So God bless to everyone.
Thank you.
Thank you.
Thanks.
Anyone here, since you came, have any other questions, comments? I'd be glad to hang out